Hi and welcome to your next session with Plato Training, where we're looking at Unit 5, Equality and Inclusion, which is part of your Dementia Awareness at Level 2 award. So the aims and objectives for the session today are to understand the importance of equality and inclusion for people with dementia. As always, please keep your eye on the top right hand corner where you will have some help and guidance with the question numbers that relate to the slides that we're on. Some important words for this unit. So dementia, you should be very familiar with the term dementia now because we're into week 4. So dementia is the disability caused by diseases or conditions that affect the brain that cause problems with the way the brain functions. Diversity. This relates to the difference and the richness and variety that people can bring to society. So it could be their cultural differences, for example. So perhaps it's different types of foods, and if you think about a market where there's lots of different foods on offer, all those smells and tastes that you would get. Equality is treating people equally, but it's not the same thing as treating everybody the same. So it's about giving people equal opportunities rather than treating everybody as if they are all the same, because we're not all the same, we are all very different. So diversity, it's about the differences that people have. If we said all cars are silver, this is clearly wrong and it's clearly silly. Of course, cars can be any colour. And when it comes to people, everyone is different, and people may have differences to one another, such as their appearance, how they look, how they wear their hair, how they wear makeup, if they don't wear makeup at all. In today's world, it's what kind of mask people wear as well. It could be their gender, their race, their culture, their abilities or disabilities, their talents and their beliefs. So why does diversity matter? Why is it important? So imagine how boring your life could be if everybody was exactly the same as one another. So think about when you perhaps walk down the street or get on the bus or go to your local supermarket. If everybody was wearing a white coat, white shoes, white trousers, and the walls around you were all white, there'd be no colour in the world. And it would be very boring for everybody to see that. Despite our differences to one another, many people still struggle to recognise and value the differences that we all have. And it's so important when you're working in health and social care, but even more important when you're working with people with dementia, that you work in that person-centred way where you are valuing and recognising the differences that that person with dementia has, so that you can work with them on their life and what they want their life to be like, or to help them to live the life that they used to be able to live independently before they got dementia. So you need to find out the whole person, because the personal history has made them who they are today. Perhaps they were keen travellers, perhaps they were perhaps they like to go on cruise ships and they've got fond memories of that, and they've met people of from different walks of life and countries, and perhaps they've been exposed to many different foods and tastes and smells, like we say, and they could still really enjoy those things in life despite being now in care, whether that is in home care or in a health and social care setting such as a care home. You can still bring those memories back for them and with them, and familiarise them again with those experiences that they had, especially in those early to mid stages of dementia, because you can look through photograph albums and perhaps ask questions about that, whereas if somebody was asking me about my holidays, it wouldn't be as tropical. But that's where we're all different, isn't it? So let's have a think now about equality. So diversity, as we said, is about looking at people's differences, whereas equality is about making sure that people are equal. So how can we encourage equality when essentially these two items are completely opposite of each other. One is about looking at people differently, and one is about making sure that people are equal. So we need to make sure that we are promoting equality, which is not the same as treating everybody the same. If we treated everybody the same, we can put some people at a disadvantage. So instead, we need to give everyone a fair opportunity based on their needs and differences to one another. So it could be, for example, that you're working with somebody with a visual impairment. Perhaps their glasses have gone into the opticians to be fixed. If you're working with somebody with a visual impairment, you're going to have to treat them differently to the person next to them who's able to see because they've got their glasses on. It could be a hearing impairment where somebody could be using hearing aids and they could find it very difficult to hear what you're saying in a room where there's other noise going on. So if somebody uses hearing aids, what the hearing aids do is they increase the volume of everything in the room. They aren't able to filter out the noises that are going on in the background. Instead, they just make everything louder. So if it is very noisy, it would be very hard for somebody with hearing aids to understand what you're saying to them because the lack of concentration is going to be there. So that's two examples of how we can treat people differently in order to give them equal opportunities. So yeah. Let's have a look at inclusion. So inclusion means making sure that people are included and that they're not left out. When you're supporting people with dementia, you'll need to ensure that you are including everybody. This could be supporting people to take part in society, because that is supporting inclusion. So when we talk about society, we're thinking about the wider community. We're thinking about things that people could do outside of those care settings. So it could be that you are tasked to do the shopping for somebody with dementia in home care. However, what does the risk assessment say? Are they able to go shopping with you? Could that be a good experience for them? Because by allowing that person to do that, if it's safe to do so, then you're allowing them to take part in society, and that is supporting inclusion. It could be that somebody is instead, it could be that there's a community group going on, something that they've always gone to, perhaps let's say a luncheon event at a local church hall perhaps, and maybe they would like to be supported to go to that so that they're not getting lost on the way and they're able to get there on time and find their way home and things. By allowing somebody to continue to take part in that lunch, they are able to be included. So it's promoting inclusion. Inclusion is quite often about removing barriers to ensure that people are not prevented from taking part in an activity. So if we think about barriers, it's things that could stop somebody doing something. So it could be, for example, that somebody would like to spend some time in the garden, but the doors are locked. And the reason the doors are locked is because there's a risk assessment in place that says people cannot go in the garden on their own. So one thing that could be done is the person might be better suited to a care home where there is a sort of inner quadrant, a courtyard in the middle of the care home, so with 4 walls around it, so it's a internal garden, but obviously still exposed to the weather and things. So that would then remove that barrier to allow that person to go out and enjoy the garden. Perhaps they've been into gardening throughout their lives. Some other barriers that we could think about, it could be a physical barrier, such as access. So that could be somebody perhaps who uses a wheelchair or a walking stick, and perhaps there's lots of stairs. An intellectual barrier, this is where somebody could be excluded because they cannot respond. So perhaps you've said, would you like a cup of tea? And the person has not replied, so you've not given them one. But don't forget that people with dementia can lose the ability to process language. So that would be an intellectual barrier. Perhaps they do want a cup of tea, but they've forgotten, lost the ability to process that and say, yes, I would. It could be a language barrier, so some people will speak different languages. A financial barrier, not being able to afford to take part in something. So perhaps if the family are looking after finances, perhaps they've not thought about the cost of, say, a taxi, because the person in care has always relied on their free bus pass. But if the buses are no longer going to be accessible in terms of safety, then a taxi would be better. But obviously there's a financial barrier to that because they can be quite expensive. An emotional barrier, so some people may feel too intimidated to take part. So if somebody with dementia is feeling particularly unsettled, they might not want to take part. But also another barrier is lack of information, so not knowing that an activity is actually taking place. So in the community there could be lots and lots of events catered for people with dementia, but if these events are not very well publicised, then it would be very difficult to actually find out about them. Recognising individuality. So as part of the Equality Act of 2010, we have a list of differences that I've put onto a diagram on the left hand side here in these little bubbles, and these are called the protected characteristics. So these are the differences that we have to one another. So the Equality Act is there to protect people from all of these differences that we may have from discrimination. So this helps us to recognise the individuality that people have. So people are of different ages, abilities and disabilities. People have different genders. Some people may go through gender reassignment. People have different races, religions and beliefs. They have different sexual orientations. Some people may be married, some may be single, some may be in a civil partnership, and some people may be pregnant or on maternity leave. And this doesn't just relate to dementia, this relates to everybody. This is a law that is for everybody in the UK. So when we think about recognising individuality, just because somebody has dementia, it doesn't mean that they automatically lose their rights to be individual or unique, because everybody needs to be able to express themselves. And if we treat everybody the same, then we're not being fair. So just for example, if you're working in a care home, if everybody in that care home was given a bed bath, even those who could walk or stand or even help themselves, we're not treating anybody as an individual. Instead, we're working with what might work for the staff that are working that day, although those staff have set themselves up for a really hard task. Respect in care. So all people working in health and social care need to show respect and dignity to the service users. So when we think about what respect means, it's about how we treat others and how we consider their feelings, their wishes and their values. When we talk about dignity in care, it's about people working in health and social care to show that respect and show the dignity by treating people as unique human beings. So we need to recognise that personal identity that the service users have, regardless of their dementia, because they still have that personal identity, the personal appearance that they have chosen to have, the way that they wear their hair. When I worked in a care home for the elderly, there was a lady, she didn't have dementia, but she was, she'd had a stroke, so she was sort of more physically disabled. She was very frail actually when I was caring for her, but she liked to have her hair blow dried, and she liked to wear makeup each day. She was very, very proud of her appearance, and that physical disability and her elderly age and the fact she was in a care home did not take that away, and it was great that she still had that choice to present herself in the way that she so wished. Culture. So when we think about culture and the dignity that people need because they're unique, this relates to their religion, their beliefs, their occupations, so what they did as a job, their relationships and their sexuality. So you may be thinking there relationships and sexuality in elderly care, but do not stereotype that old people are not interested in sex, because that is not the case. For some, it may be the case, but it's not the case across the board. So I've worked in elderly care where there was one gentleman that stands out to me, and each morning he would ask the care staff for a bottle. So if you're not familiar with the term bottle, it's just like a piece of sort of made of like cardboard, so it's disposable, and men would usually use that to have a wee when they're in bed, to pass urine when they're in bed, so it's a bit easier for them. They're not having to go over to the toilet area. He was asking for a bottle for different reasons. I'll leave that to your imagination, but that was his routine every morning. So it was great that he still had that choice to be able to do that, and that the staff were not judging him or passing comments and things. That was just who he was. That was his routine. It is very easy to take dignity away when you work in care, because you can strip people of their uniqueness and sense of belonging. So if you think about that lady that I just spoke about there, who liked to wear, have her hair done and wear her makeup and perfume as well, she was very, very happy to be up and dressed and ready for the day in the way that she felt most comfortable. Same with the gentleman that I just spoke of there. It would be very easy to take away the dignity and to say no to him for that. But why should we? Discrimination in care. So everybody is unique. I'm going to keep repeating that, I think. Service users will have differences from sexuality and relationships to how they would like their cup of tea making. Some people like milk first before their tea bag. Some people will be sat there cringing, saying, "Oh no, you don't put milk in first." That's a unique preference. When you're caring for people with dementia, you must not be discriminatory towards people with dementia, because this takes away that respect and dignity for that individual. So we need to make sure that we are not passing any judgment. It doesn't need to be a direct comment, it could be an indirect comment, so such as, making a bit of a sigh, or, "Oh, I want a bit of makeup on today. Oh, well, you can't have that because we've not got time." You're taking that dignity away by saying that. So discrimination, some examples, it could be not calling a service user by their preferred name. So if they like to be called Jack, call them Jack, don't call them John. It could be not allowing the service user to go to church or mosque, not allowing them to choose their own clothes, not allowing them to do their own care if they're capable of doing so. So there's nothing wrong with you giving a bowl of water to somebody to allow themselves to get themselves washed and dressed. That is dignity. You don't want to take that away from somebody. Not allowing a service user privacy in the toilet because you assume they will fall. If it's not on a risk assessment, then no, you don't need to do that. When we think about high quality care, you need to think back to the cup of tea making. Like I said, it could be that somebody is putting the milk in first before the tea bag, and perhaps that's how they like their tea making. We need to make sure that we are providing that high quality service, that those small things make such a big difference. And this is person-centered care. Two people could have the same condition but have very different needs. They could also make very different choices about how to manage their lives. And the whole point of person-centered care is to ensure that people make their own choices that express their own needs and preferences. So you could be working with two people that have Alzheimer's disease, and it doesn't mean that they are going to be exactly the same as one another, because prior to having Alzheimer's disease, they could have had very little in common, if anything. We're going to have a look at some case studies to help you to understand person-centered care. Elizabeth is in her late 70s but is very fit and active. She was a head teacher until she retired over 15 years ago. Since then, she's travelled all over the world and is very involved in a local history group and her local community council. She began to become forgetful and realised that she was having more trouble than other friends her age in remembering words and having sufficient concentration to read her morning paper and remember what she'd read. Elizabeth was diagnosed with having the early stages of dementia. Once she'd begun to come to terms with the diagnosis, she researched all she could to find out about dementia and the opportunities available. She organised and recruited friends for support as needed, but wanted to have some professional help as backup. Ed is 67. He was diagnosed with Alzheimer's disease a couple of years ago after his wife died. His condition has been deteriorating for some years, but his wife had covered up his increasing forgetfulness, his mood swings and his confusion, and it had not really been obvious to his family until she died suddenly. At first, his family put his depression and withdrawal down to the grief of losing his wife, but it soon became clear that he was not coping. Both of his children lived far away, and neither was able to visit more frequently than once every other weekend. Ed had been picked up by police on a few occasions as he was lost and saying he needed to get to work. He'd been employed at a local factory all of his working life. Neighbours who would regularly bring him back home and would regularly see that he'd gone out without closing his front door. On the last occasion when the police brought him back, they found the gas turned on and the front door wide open. They contacted social services because they were concerned that Ed was a risk to himself and possibly to his neighbours. So if we think about Elizabeth and Ed and those two scenarios that we've just looked at, can you see why Elizabeth and Ed would need very different levels of support even though they both have dementia? Can you see that what would work for one of them would not work for the other? So treating these two people exactly the same would not have resulted in equality. If Elizabeth was placed in 24-hour care support, she would hate it because she's at a stage in her life where she can manage in her own way for as long as possible. Elizabeth has support of her family and her friends, and she's got people able to check in on her, and she's also done her research, she's understanding her condition, and she's got people looking out for her, and she's also got the support of professional carers should she need that. If we compare that to Ed, if he'd not been supported by the support services, he could have been lost entirely. His family are only able to visit every other week, so if he'd gone missing and his family had just been that weekend, then it would be very difficult because it would be almost 2 weeks later that they would see him again and realise that he was missing, realise his gas is on, and realise that his front door was wide open. Ed is a lot more vulnerable in this situation because his support network around him isn't there. Needs and preferences with dementia. So two people can have the same condition and have very different needs and make very different choices on how to manage this, just like we just saw with Elizabeth and Ed. A person with dementia is no different from any other person who has professional carers. They still need to be in control of their own lives, they need to be in control of the support, and the support must be meeting their needs, not the needs of the service. People with dementia are often misunderstood, and society really lacks an understanding of dementia because there's a misconception that people with dementia cannot look after themselves and cannot live alone. But that's not the case because we looked at the stats that showed that majority of people living with dementia still live in their own homes. For question 1, I would like you to explain the importance of recognising that individuals with dementia have unique needs and preferences. So for this question, you need to make sure you're using your full sentences and developing paragraphs. I'd like you to try and get 3 paragraphs with around 3 to 4 sentences in each. Please pause this video whilst you complete that question. People with dementia need local communities to support them. This could be their friends, their neighbours, or local community groups. This support helps people to retain independence and stay in their own homes for as long as possible. When we think about local community support, this could be the pharmacy, who could support the person with the medication. It could be the local shop, who helps them to find essential items like milk and bread in store. It could be the neighbours, so not necessarily just the neighbour next door, but the person across the road as well. They could keep an eye on the person and look out for warning signs like an open door, like we saw with Ed. These people are classed as informal carers. So informal carers are people that support a person with dementia without payment. So people like family members, their neighbours, their friends. Many of these informal carers have been working with the person with dementia for a very long time, so it is so important that you work with them because they know the person best. If you're able to support them whilst they're caring for their loved one, then you're going to take some of that weight away from them, but by working with them, you're not stopping them from doing that care. Informal carers are classed as an invaluable source of information because they can help you to recognise and value the needs and preferences of the service user, because they might say, oh no, he likes it this way, or we always do it this way, or he doesn't like it when I do that. They've got that information and experience of working with the individual with dementia because they've known them for probably a number of years. You might be asked to support informal carers who are new to caring for their loved ones. So it could be that you are working for a home care agency and perhaps you're going out to help an informal carer to show them perhaps how to mark their Perhaps you're going to show them the care plans and what they need to fill in each day. Perhaps you're going to show them the medication log so that they can log whether the medication has been taken that day, which will then help the pharmacist and the doctors to understand and manage the condition further. So when you're helping to support the new informal carers, you would need to tell them about person-centred care and the importance of doing things the way the person liked, as well as all of the factual things. You need to be able to educate that informal carer about doing things that the person with dementia has always done or has always liked. So we can help the informal carer to find out the unique care needs and preferences by asking the service user if they're still able to communicate that. You could ask the staff or the managers at the care home or the staff or the managers at the home care agency if they're already familiar. You could use a life story, so you could actually create a life story. You could try and gather information from the different people that this person knows. You could ask other friends and family members and partners and neighbours for the information that would help you to fill in that life story as well. And you could ask the multidisciplinary team. So what I mean by that is, like, say for example, the GP, the pharmacist. Perhaps they've known this person for years and they're able to paint a bit of a picture as to who they are. By making sure that the informal carer understands the unique care needs and preferences of the individual is going to really help to make the informal care a success. When we say about asking the service user, it obviously depends on the mental capacity, and it also depends on the questions that are being asked. But the first person you should tell the informal carer to ask is, of course, that service user. Only when the person is unable to speak or to answer those questions should the life picture of that service user be explored through different options. So remember that when somebody is an informal carer, such as a family member, a friend, a life partner, it can be a very demanding and lonely role. So it could be that that person is the only person that is there 24 hours a day, 7 days a week, and it can take its toll being a informal carer, especially because you also have that bond there, that loving bond. So when carers are introduced to local community help and support, they might feel a sense of relief, because when you're supporting carers, you should be sensitive to their feelings. They could be very angry or upset that day, but they could also be quite happy. We just don't know. You need to value their work, so tell them they're doing a good job. Explain and give information that they can use, such as community help and support, as above. You could reinforce information by writing it down, so it could be very overwhelming if you're giving them lots of information at once verbally. It could be beneficial if you just write down some of the places and names that you're talking about, and perhaps the numbers if you could find them. You need to show the person how person-centered approach works. And you could use your work as an example. So it could be that you say, oh, when I worked in another person's house, I was working with Doris, and Doris really liked her meals really, really hot. And we looked at it in terms of risk, and it wasn't deemed as a risk, because when we say really hot, we don't mean sort of volcanic hot. We mean putting it in the microwave for an extra 30 seconds or 1 minute. And that's fine if it's past a risk assessment. If your managers are aware of it, that's fine. And if that's how Doris prefers to eat her food, then that's also fine. I worked with a lady that was 108, and she liked her meals to be heated up for an extra minute. That's where that story comes from. But it's a perfect example of person-centered care. For question 2, I would like you to describe the importance of helping informal carers and others to understand that individuals with dementia have unique needs and preferences. So again, if you can write 3 full paragraphs of at least 3 sentences each. You should now be able to understand the importance of equality and inclusion for people with dementia.